Wow, this is a big room. I am so glad to be here today and so glad to have an opportunity to spend a little time with all of you. I'm going to actually be as brief as possible this afternoon because, quite frankly, I think it's much, much more interesting for us to have a conversation than for me to blather on forever. I'm going to kind of talk about a few things. I'm going to do a short chronology about my experience and my personal journey through HIV, through the period of time that I've been involved in the epidemic. Not necessarily because my story in any way exemplifies the macro story. There are certainly huge limitations. Now, I remind people all the time that history is his story, but it does give you, I think, a perspective over the longevity of the AIDS epidemic and maybe create some opportunities for us to be in dialogue with each other. Then I'm going to provide you with a little overview of the Black AIDS Institute, what we do, what is our model of change, how we work, in addition to sharing with you some data from a recent KAB, a knowledge, attitude, and belief study that we did domestically in the United States, and then talk a little about kind of a reminder of what the AIDS epidemic was like in the early days, at least from my personal perspective, and quite frankly, how it's like in some parts of the world still today from a very personal perspective. And then we'll open it up to open up the floor for discussion. So why don't we get into it? In 1980, I came out. I discovered that I was a gay man. And what's interesting about that, as I tell the story, it actually was as much a surprise to me than it was to anyone else. I actually hadn't thought about it at all. I have finished college. I'm the oldest son in my family. I come from a long line of Black Baptist ministers. So most of you understand the minister part. Some of you might not understand the Black Baptist part or what that means. Does anyone actually know anything about the Black Baptist tradition? Raise your hand if you know anything about that tradition. Okay, we have a few people who understand that the Black Baptist tradition is one of the conservative traditions and faith in the United States. It's actually one of 7 historically Black, historically American religions. And so I come from a long line of ministers in that background. In fact, I taught Sunday school at our family church, and so I was very, very involved in that. And literally, I was engaged to be married, and we were having a hard time. We had been together all through college, and 3 years after college, and we were kind of approaching marriage, and I, quite frankly, was internally freaking out. And I didn't understand exactly what the problem was. And one day, literally, I was driving to work and I heard a radio interview, and it was like a light bulb had gone off in my head that that's the problem. And I went back home that evening and sat down with my fiance and said, we need to have a conversation. The next day, I went and I found every book I can get my hands on about homosexuality, and I brought them home to our living room, and we sat down in the living room and read about homosexuality. Loving Someone Gay was one of the books. Ruby Fruit Jungle was another book. Being Gay in America was another book. So here the two of us, my fiance and I, kind of going on this exploration together. Fortunately, she was very understanding of the conversation. Not that it was an easy conversation, I want to be clear about it, but we worked through it. And literally within, I would say, 2 weeks, I told my parents, I told my siblings, I told my minister, and I hadn't actually even had a sexual encounter at that point. And so people ask, well, how did you know that you were gay and you hadn't even had a sexual encounter? And my point is that sexuality is not just about sex. It's not just about the function of having sex. Now, it is about relating to, and it's about the emotional connection that one has, and it's about understanding who you are more so than it is about anything that you do with another person. So shortly after that, I actually did meet someone His name was Chris Brownlee. We fell in love, and we began our journey together. This was 1980. In 1981, the CDC reported the first HIV/AIDS cases in Los Angeles, California. 8 white gay men were diagnosed at UCLA by Dr. Michael Gottlieb. That same year, Chris went to the doctor and discovered that he had swollen lymph nodes. He came home and he talked to me about the swollen lymph nodes, and I noticed that I had swollen lymph nodes as well. And all we knew at the time was that there's something about this new disease and swollen lymph nodes. And they did a biopsy of both of our lymph nodes, discovered that they were abnormal, but that was all they knew. I'm not quite sure why we even did the biopsy, because before they did the biopsy, they knew that they didn't know anything. But nevertheless, we did the biopsy. Later that year, the New York Times carried a story about a rare cancer seen in 41 homosexuals. The article described cases of Kaposi sarcoma among 41 gay men in New York City and San Francisco. By the end of that year, 121 people were known to have died from what would soon to become AIDS by the end of that year. Later on that year, Chris and I had been involved in gay sports, gay softball and gay volleyball and gay bowling. And in August of that year, one of our teammates missed a game. 2 weeks later, he was dead. And that was our first connection to the disease. Literally, he was at practice on a Saturday. The next Saturday, he missed the game, and by the 1st of September, he was dead. In February, we decided to move to Los Angeles in 1982. We decided to move to Los Angeles because if any of you have been to Chicago, Chicago is cold, very cold. That particular January, for 30 days, every weekend, the temperature was 15 degrees below zero, counting wind chill factor. And so one day, I came home and I said, it's time to go. That Monday, I walked into my office and I said to my boss at the time, I worked for AT&T. As I look around this room, I know that none of you are going to relate to this. Back then, there was one telephone company. It was called AT&T. And the only phones that people had hung on walls in usually their kitchen. It was determined that the telephone system was a monopoly. There's a judge called Judge Green said you have to break up this monopoly. And so AT&T, which was the only telephone company, had to break up. I was on the team that was responsible for the divestiture, creating how we were going to break up this massive company into small companies. This is an important fact because I'm going to come back to this about leveraging, and this is important to understand how you can leverage. So I went into my office on Monday, and I said to my boss, I need to move to Los Angeles. And he said, are you crazy? He said, we're in the middle of the biggest divestiture on the history of the planet, and you're a part of that team, and we're not doing transfers. I said, oh, no, you don't understand. Here's the deal. In 2 weeks, I'm moving to Los Angeles. That's not debatable. The question is, when I get to Los Angeles, am I going to be working for you, or am I going to be working for the new competition? And by the way, did I mention that I'm on the divestiture team? I'm just saying, you decide. Well, not 2 weeks, but 3 weeks later, we were in our car moving to Los Angeles. And I had a job when I got to Los Angeles. Now, that's the way that worked. Part of it is that, my God, I was 25 years old. We didn't have any dependents or any responsibility. You can be that bold. But part of it was understanding your worth. And that's important no matter what you're doing. Number one, to be good at it. And number two, to understand your worth. And leverage becomes important throughout one's career. So we move to Los Angeles. We get to Los Angeles, and there's a new conversation going on about HIV. Actually, not even HIV quite yet, but the Kaposi Sarcoma Foundation in San Francisco had come down to Los Angeles about responding to this new disease. The first place they went was the Gay and Lesbian Community Services Center in Los Angeles, which was the biggest organization to respond to what was already identified as the primary audience being impacted by HIV by that time. And the folks at the center decided that they didn't want to address this issue. They didn't believe that it was going to become something that the gay community should pay attention to, that it wasn't their problem, that somehow what was happening in San Francisco and what was happening in New York was not going to happen in the same way in Los Angeles. It speaks to the power of denial, because remember, the first diagnosed cases of HIV actually happened at UCLA. And yet, the gay community in Los Angeles didn't feel like they were going to be impacted by the epidemic in the same way that San Francisco already had been impacted and New York had already been impacted. And that this whole way of thinking would plague us, pun intended, would plague us throughout the history of fighting the AIDS epidemic, that people believing that it's not our problem, no matter how you define our problem, that it's someone else's problem, that people, desperately trying to figure out how they were different than people who were getting infected and getting sick and dying, and totally ignoring the ways that they were the same. Later that year, we started the first candlelight vigil in Los Angeles, which eventually became World AIDS Day, although this first candlelight vigil actually happened in March of that year. By 1985, there were thousands of people who were infected and had died from HIV. Our lives literally turned into a process of spending time in hospital rooms, spending time in deathbeds, helping people actually transition, delivering memorial services, and actually burying our friends. By late 1985, Chris developed his first case of pneumocystis pneumonia. He woke up one morning and he literally could not breathe. We raced to County General Hospital, and in the emergency room, there was a room that was designed to service 12 beds. When we arrived there were already 24 beds in this room designed for 12 beds. The beds were so close together that you could not move one bed without bumping against the next. They had brought in gurneys, so the hallways were lined with gurneys because there were too many people and they did not have enough beds. And so you had IV poles, you had all sorts of medications going on where there's no sense of privacy whatsoever. Physical examinations where patients were literally exposed in front of whoever else was in the room. That was our introduction to public health in Los Angeles County in 1985. Later on that year, by early 1986, they had developed the first HIV test. They had discovered that the disease was actually a virus, actually a retrovirus, and they had isolated that. And in California, when we were starting to build a response to the AIDS epidemic, primarily in the LGBT community and primarily in a time where the government was not responding at all, an interesting thing happened. California has this electoral process called initiative. So it provides an opportunity for local citizens to put anything on a statewide ballot, and instead of elected officials determining the law, direct action by citizens can make things into law. And so there's a ballot initiative on the ballot called the Lyndon Larouche Initiative. And it was an initiative that would quarantine anyone living with HIV in the state, literally putting people into quarantine. We decided that at that point, the LGBT community decided that we really had to go all in on this battle at this time. And it became the first major political battle around HIV. We mobilized communities. For the first time, the community also realized that we needed to mobilize beyond our local community. And so we needed to reach out to ethnic communities. We needed to reach out to the women's community. We needed to reach out all across the state to talk about HIV for the first time as both a civil rights issue, a justice issue, and a health issue. It was also an opportunity to share with the rest, in that case, the rest of the state evolved into the rest of the country, how we are all impacted by this issue, whether you're infected or not, and how stigma, in fact, can threaten all of our health. It was also the first time where we began to really look at the impact on race in HIV. The truth of the matter is that from the very, very beginning, when they started, in the beginning of the epidemic, they didn't track the epidemic by race. So when the Lyndon Larouche initiative happened, we went to the CDC and we said, you are collecting this data. You need to divide this data in a fashion that relates to folks. Up to that point, they were only tracking the data, they're only publishing the data by state and sometimes by county. So we insisted that they begin to break out the data by gender and by race and by age. What we discovered at that point is that women were actually being infected by HIV. Up until that point, we didn't really realize the magnitude of the epidemic among women. We realized that people of color were disproportionately impacted by the epidemic. We realized that the epidemic wasn't just a homosexual epidemic, that heterosexuals were impacted by the epidemic. In fact, what we found out was that 25% of the population impacted by HIV in 1986 were black. So as far back as 1986, we knew that blacks were disproportionately impacted by the epidemic. We knew as far back as 1986, at that point, 10% of the cases were women, even though there was no effort to address AIDS among women at that point. And over 50% of the cases among women were black women. So that was an eye-opening experience for us to understand the breadth of the epidemic. And then that begins to speak to how important it is to understand what you don't know, and I'm going to come back to that later, and to figure out ways to find out what you don't know. That all too often, we center ourselves from our perspective, from where we sit, where we stand, that we think the view of the world is consistent with our view. And I'm always reminded of have you heard the story of the blind man and the elephant? If you've heard that story, raise your hand and I won't. So a few of you have heard the story about the blind man and the elephant, but since a lot of you haven't, it is kind of a funny story, that there are these 5 blind men and they're trying to describe an elephant. Okay? And so one of the blind men, actually is leaning against the side of the elephant. And he says that the elephant is like a wall. It's big and it's hard and it's solid. Another one grabs a hold to the elephant's leg. He says, well, no, you're totally crazy. An elephant is like a tree, like the trunk of a tree. You can wrap your arms around it, and it's big and it's sturdy and it's settled into the ground. And another one grabs the elephant's husk, and he says, you're crazy. It's like a spear. That's what an elephant is like. And another one grabs the tail and describes it as a rope. And another one grabs the trunk and describes it as a snake. Each of them describes the elephant from their unique perspective. not understanding that it requires this perspective of all of them to actually describe an elephant. And so is the case often, when we talk about health issues, that we need to find ways to gather in the perspectives of folks who see things differently and whose experience are differently than our experience. And that was one of the important lessons that we learned in fighting the Larouche initiative in California. Well, we won that battle, and we beat back the Larouche initiative. And I think that the fight against the AIDS epidemic was forever changed at that point. It took us a while to actually get it. No, it took us a while to really embrace all the differences of HIV, but I think the seeds of understanding that difference happened in that campaign. I'll kind of race ahead to 1989, and by 1989, we had a number of the early drugs. We had AZT, we had D4C, we had 3TC, so we had three major drugs, but they all were of the same class. They all were very, very toxic, and they never actually really did more than delay the onset of the disease. In 1989, in August of 1989, Chris and I decided to go on a trip to the Grand Canyon. And by then, he had what's called a hep lock, which is a way to receive medicines directly into your veins, into your wrist. And hep locks normally last 4 or 5 days before they have to be taken out. And we were going to be gone for 2 weeks. And so we set up this process of we were going to be at the Grand Canyon, so we set up this process of finding a doctor in Phoenix, and finding another doctor in Sedona, so that we could go to have this hep lock transferred out. And so after about 4 days, we went down to Phoenix to have the hep lock changed, and the doctor would not do it because he would not see a patient with HIV. This is 1989 now. And so the hep lock hadn't clogged yet, and so we decided that we would kind of see how long it took. And in actuality, that hep lock lasted for 2 weeks. So our entire trip, we were able to make it with the hep lock in place. And it was kind of funny, the drive to the Grand Canyon. We would pull off at the side of the road, put up a IV pole, hang his meds on the IV pole so that he could get his meds to keep moving. Which was an interesting sight, with the cars driving by and the trucks driving by, and there's this car with an IV pole and meds coming out. Part of that, and I think that's important, is how creative we can be when we have to be to address issues. We wanted to go to the Grand Canyon, and we particularly, although we didn't completely understand why it was so important to go to the Grand Canyon, but we knew we had to get to the Grand Canyon. And so we finally reached the Grand Canyon, and first we were going to drive all the way into the Grand Canyon to where we were staying, and we decided, no, we're going to stop at the first lookout station. And we stopped at the first lookout station, and the two of us were standing there looking at the Grand Canyon, and we just started to cry. We had never seen anything that was so beautiful in our lives. And the experience was a remarkable experience. We went hiking, and we went swimming, and we went off-road biking, and what have you. And we got back to Los Angeles, and at the end of August it was, and in November, Chris woke up and he could not see. And by November 28th, he was dead. And I want to share with you an incident that happened connected with his death. It's weird, so very weird. It's probably the weirdest thing you'll ever experience. The jarring sound of the phone ringing startled me. I wasn't asleep, but because I hadn't slept in days, I wasn't quite awake either. Is this the Chris Brownlee Hospice? asked an unfamiliar voice. By the way, we named the hospice after him, and so at this point, he's in the hospice, and so there's this call that comes in. Yeah, I guess so, I stuttered. It was 3 a.m, and all I could wonder was who would be asking such a question at this hour, and in such an insistent tone. "Who is this?" I said. "May I help you?" "Can you confirm what time Chris Brownlee died?" The voice demanded rather than asked. You've got to be kidding me, I thought. This whole thing had seemed like a dream. I guess this call meant that the nightmare had taken an unexpected and unappreciated turn for the worse. "I beg your pardon, who is this again?" "I'm sorry, this is the LA Times. I'm on deadline. I already have the obituary. I need to confirm the time of death." "Listen, I'm Chris Brownlee's partner. I don't know who you are, but he's not dead yet. Thank you very much. I'll tell you what, when he does die, I'll make sure someone calls you." "Oh, I'm really sorry," this time he stuttered. "I didn't mean, I know you didn't mean to," I said, "but you really need to find a better way to do this." I hung up the phone and quietly went back to my vigil. It's feeling cheated because it was supposed to be forever, and it was only 10 years. It's the breaking of your heart every time you have to leave him in the hospital. It's having to leave him in the hospital too often. It's being a member of the team that makes the decisions about his care. It's making the final decisions all by yourself. It's the echo of his voice in your ear on the eve of his death when he says to you, "Take me home." It's the echo of your voice in the hollow of your heart, created by the pain of the loss. It's saying, "I'm fine." I'll take care of everything. I'll handle it. It's discovering that you're not fine. You can't take care of anything, and this time you can't handle it. It's giving his body to the undertaker and getting back a plastic container the size of a shoebox to represent 38 years of a person's life. It's feeling the pain of knowing each bit of hurt is a celebration of the love you feel for each other. It's the chuckle of his voice when he awakes from the coma in the middle of the night to tell you that he loves you. It's telling him you love him as he takes his last breath. It's holding him and feeling the warmness of his life leave his body. It's driving down the freeway and being blinded by your tears. It's not knowing that you are crying. It's wondering what will happen to you when your time comes and he's not there to tend you. It's knowing he will be there. It's the numbness, the panic, the fear, the sadness, the blind rage over what's happening to you. It's remembering in the middle of the day and feeling as if it were happening all over again. It's the loneliness because you have no other friend like him. It's calling your landlord to find out how much the rent is, or calling the bank to find out what your balance is because he did those things. It's sitting at home and wondering what's keeping him because you forgot he's not coming home. It's keeping the tape on the answering machine because it is a way of hearing his voice. It's being glad to return home after a trip because you know the cats miss him nearly as much as you do. It's keeping his driver's license, wearing both your wedding bands, isolating yourself from family and friends because you don't know what else to do. It's wishing he were here. It's knowing that he is. It's telling him it's okay. It's telling him that you'll be okay. It's believing if you work hard enough, fast enough, long enough, if you keep him on the cutting edge of treatment, maybe he won't die. It's the anger when he dies anyway. It's the guilt because maybe you didn't work hard enough, fast enough, or long enough. It's the hopelessness of knowing even a love as great as yours could not save his life. It's chronic. It's not manageable. It's not over, even after he dies. There are some things I learned in having a person that you love die in that fashion. I learned how it felt to really be in love with someone. I learned how to focus passion. I learned how to go on, how to keep focus. 1989, on the morning when Chris died and the undertakers came to take his body away, I didn't know what was going to happen, but I did know that I had work to do and I had to focus, because if I did not do that work, then that would be as if I was a part of killing him all over again. And so for this time, and now it's been over 20 years since he died, what keeps me going is knowing that the work that we do and the work that you do is a reminder that those lives mattered, that they were not forgotten and they were not in vain, and that we are in fact here today having conversations that no one would have ever imagined we could have in 1989 about ending the AIDS epidemic. And it's because people kept doing the work and kept moving forward. And that, in fact, wherever we are part of the journey. And we're part of the same journey. It's just that some of us are at different places in the journey. Last year, I went on a trek from the southern tip of Vietnam to the northern tip of Vietnam. And one of the things that I discovered along the way is that you run into people on treks like this. And sometimes you run into people who are going in the opposite direction, but sometimes you catch up with people who are going in the same direction. And sometimes you get to hostels or to places and you look in the guest books and there's the name of someone that you saw a day before or 3 days before. And a lot of this journey is about that. We are on the same path. It's just that we're at different places in the path. By 1996, I was having my own health challenges with HIV. In November of 1996, my doctors called my mother, who lives in Chicago, to tell her that she needed to come to Los Angeles if she wanted to see me alive. My mother said, well, how much time do I have to prepare, to pack, to make arrangements? The doctor said, well, if you hang up the phone and you immediately go to the airport and you're lucky enough to catch a flight right away, maybe he will still be alive when you get to Los Angeles. I was in the intensive care unit at Kaiser Permanente Hospital on Sunset. I was in a coma, and they had given me less than 24 hours to live. My mother arrived in Los Angeles, and it just so happened that I was one of the first patients off protocol in Los Angeles to receive the new protease inhibitors. And I survived, obviously, that bout. I went from not being able to move from my hospital bed to the bathroom to now having run 8 marathons. And I'm alive today. I am undetectable today. My viral load is under control. I work too hard today. But I personify what can happen when people living with HIV have the love and support of family and friends, when we have access to the care and treatment that we need and we deserve. I personify what happens when communities come together. During this journey, there have been a number of times when we have had what I call Sophie choice decisions, what I call false debates. One of those events happened in the mid-90s when we were having the debate around whether or not we could deliver treatments to developing countries, particularly in sub-Saharan Africa. And I remember that there was a debate on whether or not we should focus on prevention or whether or not we should focus on treatment. And at the International AIDS Conference in Durban, I was asked to participate in such a debate and to be on one side of the question, either to be on the treatment side of the question or to be on the prevention side of the question. And so I agreed to participate in the debate. But when I got up to speak, I basically said, this is a stupid debate. You know, why are we having this discussion? That we need to do both, and we have to do both. And what we discovered, that we in fact could provide treatment in sub-Saharan Africa. And as a result, two things happened. When we started to provide treatment in sub-Saharan Africa, our prevention strategy became much more effective because we could then be engaged in conversations with people who were living with HIV. And that the truth of the matter is that every new infection requires two people. There's not been an infection that did not involve two people. One person is an HIV positive person, one person is an HIV negative person. It requires both parties to transmit the virus. It only requires one party, either party, to stop the transmission. And up to that point, we were only having serious prevention conversations with people who are HIV negative. And we're ignoring people with HIV positive who actually play a critical role in the prevention conversation. And starting to talk about treatment allowed us to have that conversation in a robust way. More recently, we're having another absurd debate over biomedical intervention or behavioral intervention. And again, it's a stupid debate. We need both. In recent years, the scientific advances we've made have been tremendous. Now, the fact that we now have treatment as prevention, that if we can help people who are HIV positive to get on treatment, we can get their viral load under control, that we can reduce transmission by up to 96%, that's a remarkable advance. The fact that we now have PrEP, that when properly administered, we can help people who are HIV negative, even when exposed to the virus, reduce their ability to acquire the virus by 96%. That's remarkable. That's the biomedical interventions, tools that we now have that we didn't have. But you know, we have those kinds of biomedical tools for syphilis and gonorrhea and have had them for over 75 years, and we still have a syphilis and gonorrhea problem. The biomedical technology is not going to get us there by itself. Every night, I sit down and I take my meds. I take 3 pills every night. And I look at those pills every night, and you know what I observe? I observe that not one of those pills have the ability to get into my body without my help. Not one of them. So my participating and getting those pills in my body, what is that? That's behavioral. So it's the marriage between behavioral and biomedical that allows us to move forward and have conversation about ending the AIDS epidemic. And so across the board, we run into these black or white conversations that are often full of gray. And we have to understand that we should not be talking about these either-or situations. In most cases around HIV, in most cases around public health in general, it's an and conversation to be having. You know, in a lot of places today, we definitely need to continue to focus on HIV, but we also need to put HIV into the context of a larger public health conversation. That looking at HIV as an isolated disease state is probably no longer appropriate. That figuring how to target and to put it in context is going to be the way forward. That Sophie's choice is not a Sophie's choice that we should be making. The other thing that we need to look at around the Sophie's choice, and that's the next step that I'm going to talk about, is kind of the relationships between the medicalization of HIV and working with communities to fight HIV. Now that we have new biomedical tools, now we are not focusing as much as we were focusing on the role of communities, and communities will continue to play a vital role in fighting the epidemic. So clinicians need to figure out new ways to engage communities, and communities need to figure out new ways to be ready to fight in this new paradigm around HIV that involves biomedical interventions, and in the case of the United States, involves what's going to happen with things like the Affordable Care Act and the way we deliver health care in the United States. So in 2012, the Black AIDS Institute initiated a national survey of the AIDS workforce. It was the first time that anyone had done a knowledge, attitude, and belief survey of folks who are work and volunteer in HIV in the United States. And so I want to share with you some of the data from that survey. And being reminded of the thing that you never know what you don't know until you know it. And so here's where, actually, how do I go back? Because I moved ahead too fast. Maybe we will try this. Does that do it? Okay, great. Yes. So we launched this survey in 2012. We partnered with the Latino Commission on AIDS, the CDC, NASDAQ, Johns Hopkins University, and Johnson Pharmaceuticals. Here's the treatment cascade in the United States. Is everyone familiar with the treatment cascade? It shows how well we are doing in the United States to fight HIV and to get to an AIDS-free generation, or around viral suppression. In this case, we're looking at the cases in the United States. We can do treatment cascades all over the globe. Today, we're already breaking these cascades down to local communities. So in the United States, we are basically diagnosing about 82% of the 1.15 million Americans living with HIV are being tested. They are being diagnosed. We know that they have HIV. They know their HIV status. It's not great, but it's not terrible. Unfortunately, now we lose about 20% of those folks to care. So from the point where they get tested, 20% don't get into care at all. So we're at a point where 66% of folks living with HIV are in care. So over 30% of folks are not in care at all. But then the wheels really fall off. Now, we're not able to keep folks into care, so only about 37% are retained in care, and only about 25% have optimal care, meaning they're reaching viral load, which goes back to the point of reducing ability to transmit the virus. When I say that if we can help people get to viral suppression, we can reduce transmission by up 96%. To do that would virtually break the back of the epidemic. Well, we're only doing that successfully with about 25% of the population in the United States. And so the question is, how do we do better? Now, how do we move that needle so that we have more people who are at viral suppression? Because if we are successful in that half of the equation, we combine that with what we can do with the other half of the equation, we actually can functionally end the AIDS epidemic. It's not a cure, it's not eradication, but we can functionally end the AIDS epidemic, and we have that capacity in the United States today. So in 2012, we launched this initiative in partnership with a number of organizations. What we wanted to do is to better understand what the HIV/AIDS workforce knows and does not know about particularly treatment, biomedical interventions, and clinical interventions in the United States. The survey was an online survey. We started it in 2012 with a pilot in Las Vegas. By 2013, we launched it in 48 states. We did a Spanish supplemental in October of 2013. All in all, nearly 2,200 folks participated in the survey. The participants had to be 18 years or older. They had to volunteer or work in an AIDS, in an AIDS organization, and their work in this case primarily focuses on in the U.S. There are 21 screening questions, 26 knowledge questions, looking at basic terminology, science and treatment, biomedical interventions, and there are 15 questions that focus on familiarity and attitudes toward the newer biomedical interventions. So let's cut to some of the kinds of questions we ask. What does HIV stand for example? What are the criteria for diagnosing AIDS? What kinds of biomedical interventions are offered? Those kinds of questions. So let's cut to the results quickly. So the results range from questions where people got 96% correct down to questions where people only got 23% correct. People did better on basic knowledge than treatment or clinical care. What we found that on basic knowledge, there was a 76% competency on basic knowledge and terminology. I want to remind you, these are people who are working in HIV, okay? So, on treatment, there was 55% competency. And on clinical biomedical interventions, a 45% competency. Now, since we're at an academic institution, all of you will be familiar with what grades one would get if you scored this well in a final exam. So overall, people are getting a D. Again, people working and volunteering in HIV, getting a D on their knowledge around HIV science and treatment. On basic knowledge, getting a C. And failing in treatment and clinical and biomedical interventions. We found that there were some things that showed people doing better than others. I say better because no one did well. If you had a graduate education, that was an indicator that you would do better than others. If you were a member of the LGBT community, that was a correlate to doing better. If you're HIV positive, that was a correlate to doing better. If you were Hispanic or Latino, that was a correlate of doing worse. If you're African American, that was a correlate of doing worse. If you worked in the South, that was a correlate of doing worse. And if you worked for a small organization, there was an association with doing worse as well. So, but those relationships were not dramatic. So for example, if you had some graduate education, you scored about 67% overall. Basically, you were getting a D. If you had less than an associate's degree, you only scored a 54% competency. How long you were in the field mattered. If you're in the field for over 16 years, you scored around a 69%. If you're in this field under 2 years, you scored around a 60%. So it mattered, but not to a dramatic level. There was a difference between people who worked in the government and people who did not. If you worked in the government, if you worked for a health department, you scored about 65%, still poor. And if you worked for an AIDS service organization, only a 61%. Now, so health departments, who are folks who are setting health policy, are only getting a D in their knowledge of HIV science and treatment. There were a race correlation. Blacks and Latinos scored around a 59%. Whites scored about a 66%. Then we wanted to find out if familiarity had a relationship between knowledge. We discovered that there was a relationship between familiarity and knowledge. So about 37% of the respondents were very familiar with PrEP. Only 26% were familiar with microbicides. Only 27% were familiar with vaccines. And only 44% were familiar with treatment as prevention. So that means that the majority of folks who are working in HIV and AIDS are not familiar with vaccines, are not familiar with treatment as prevention, not familiar with PrEP, and not familiar with microbicides. We did discover that there was a strong relationship between if you're familiar and how well you did on the knowledge part when it came to PrEP and treatment as prevention. So if you're familiar with PrEP, you did better knowledge-wise than if you were not. If you were familiar with treatment as prevention, you did better than if you were not. Interesting enough, it did not matter if you're familiar with vaccines or familiar with topical microbicides. We think that might be because with PrEP and treatment as prevention, there actually are tools that are available today. We don't really have a microbicide tool that's available, and we don't have a vaccine. But nevertheless, that was an interesting correlation. We also wanted to figure out if there's a relationship between knowledge and your belief in the efficacy of biomedical interventions. And we discovered every step of the way that there was a relationship between knowledge and your belief in the efficacy. If you believe, for example, that PrEP worked, you tested higher on the knowledge part. If you believe that topical microbicides work, you tested higher. And particularly if you believe that treatment as prevention work, you tested higher. Now, the survey wasn't designed to tell us what's the chicken or the egg. No, did you know more because you believed, or did you believe because you know more? We don't know the answer to that question yet, but there was a relationship between if you believed in the efficacy and knowledge. This slide is important because at the end of the slide, it really tells you how knowledge of your ability relates to your to communicating. So what this slide tells us is that people who believed that they knew a lot about HIV, they felt they were better able to talk about, knew a lot about biomedical interventions. They felt that they were able to talk about, and in fact, were talking about biomedical interventions to their constituents. And you see that in the two bars in the middle on the second side of the slide. This slide here just breaks down the data by race in all of the areas between topical microbicides, viral load, pre-exposure prophylaxis. So the conclusion of the study basically is that the vast majority of people who are working and volunteering in HIV neither have the knowledge they need to advocate for these new biomedical interventions, nor do they believe that these interventions actually work. These are the very same interventions that we are tagging our hats to when we talk about how we're going to end the AIDS epidemic. So why is a study like this important? It's important because up until this point, we've been developing strategies around educating folks in the field and educating folks around HIV with not knowing what they know and what they don't know. And part of the lessons that we need to talk about in public health is that you have to take the time to do community assessments. You have to take the time to know what baselines are, and you need to build on those baselines. And the other thing, a part of this, is developing the trust in communities to be able to do the work. So the next thing I want to talk about, and then I'm going to I'm kind of throwing out some thoughts for us to engage in conversations, not trying to go really deep on any of these topics, but to give you some areas to discuss and how maybe some of these conversations relate to the work that you do or questions you might have about around the work that you do. So the Black AIDS Institute was founded in 1999. We're the only national HIV/AIDS think tank in the United States that focuses exclusively on Black people. Our mission is to end the AIDS epidemic in Black communities by engaging and mobilizing traditional Black institutions, leaders, and individuals in the fight against HIV and AIDS. For the first, I would say, 12 years, maybe 10 years of our existence, we focus almost exclusively on building infrastructure in traditional Black institutions. As a result of what's happening with treatment as prevention and the new biomedical interventions, we kind of changed our focus because we understood that what was really imperative is to figure out how to create a marriage between community mobilization, biomedical interventions, and behavioral interventions, and then how to connect health systems to people working in the community. And so as a result, we developed this model. And so in this model, what you see is that now in the cities that we work, the first thing that we do is to do a readiness assessment of the community. Figure out where the community is before we do any work at all. For a lot of occasions, what happens is that people kind of parachute in and make assumptions about where a community is, and then begin to work, only discover that they're not effective, and often they're not effective for two reasons. Because the work that you're doing may or may not relate to where the community is, or number two, the community may not have a buy-in in the work that you're doing. So the first thing is to do the community assessment and to build buy-in on the state level, on a city level, and among ASOs and CBOs. At that point, then we divide into two tracks. One is a technical assistance track, the other is a training track. In the technical assistance track, these are some examples of the kinds of technical assistance that we provide based on what we find out in the readiness assessment. But technical assistance on community engagement, technical assistance on testing issues, technical assistance on HIV planning, on social marketing, on the continuum of care, all of those areas which are critical, on high impact prevention, all of these areas which are critical components on moving the dialogue and having better outcomes in the treatment cascade. And then we go to training and providing training again where people are. Our trainings are divided into high intensity, medium intensity, and low intensity. The point is that not everybody can do everything, and not everybody has to do everything, that you can develop options or menus to engage folks. So our high intensity training, for example, is our program called the African American HIV University. That's a year-long program. Anybody familiar with year-long programs in this room? It's high intensity. The first course is 30 days on UCLA's campus. So for 30 days, people have to leave their homes and what have you, and we spend 30 days with them, total immersion on UCLA campus. Classes 8 days a week, homework every night, study groups every day, quizzes every day, every morning, tests every week, and you have to score a minimum of 75% to stay in the program. So that's the first month. Then you go home for 90 days for an internship, and then you come back for a week-long training, and that repeats itself 3 times. So a total of 4 trainings. The first training is 30 days, and 4 internships. Now, what we discovered in a cohort that we just finished is that we went back to that KAB I talked about, and so we provided that as a pre-test for people we just took through the training. What we discovered is that the cohort of folks that we just sent through our training scored about the same as the folks that work in HIV, basically in the mid-50s when they came to us last August. At the end of the first 30 days, they scored on average in the mid-90s. So after 30 days, they moved from the mid-50s to the mid-90s, okay? So then, my staff was excited about that. I said, that's fantastic, but we just had them for 30 days. They didn't have to do anything but this. Their scores should go up in that amount of time. But then they went back out into the field, and as we all know, life happens, and then they came back 90 days later, and we tested them again. They had lost some, but they were in the mid-70s, still dramatically higher than they started, but they had lost some. At the end of that first week, they were back up to the low 80s, still not all the way up to the 90s, but in the low 80s. They went again away for 90 days. They came back. And they came back, and they didn't lose anything. They came back after being away for 90 days, and they were at the same place that they were when they left. At the end of that third week, they're up to the mid-80s. So then they came back after 90 days, and they didn't lose anything again. They retained again. So they came back in the mid-80s, and when they finished the entire year, which was in May, their final score was in the mid-90s. So what that tells us is that people, in fact, can learn this stuff, and they can retain this stuff, and most importantly, they can do something with it. So that's an example of a high-intensity intervention. It's an example of taking baseline data, and then applying it in real life and seeing what kind of outcomes you get. It's not enough to simply say that people don't know. You have to develop a program for them to learn and to apply it. We then have other trainings, local trainings, webinars, low-intensity trainings, so that we can supplement the work of our core group, but that we can offer opportunities for other people who cannot, for example, come to Los Angeles for a whole month. All of this work then translates into opportunities for people to actually build institutions in the ground. So all of our fellows have to build local Black treatment advocate networks in their local communities. Those local networks have 4 priority areas, and those priority areas tie into the treatment cascade. One is treatment education. They have to have a priority area where every month they're providing treatment education. Number 2 is patient navigation. Again, every month they need to figure out ways to look at their population that's not in care in their local community to get them into care. Because after all, isn't that the ultimate goal, to get people into care? They need to look at voluntary disclosure as a way to address the stigma and to help people figure out ways to develop their personal support network. And then they have to have an advocacy campaign. Because of the moving forward in fighting HIV, advocacy is critically important, but you need to have advocates that are educated and informed about what you're doing. You really need to have people who know their work, and so that's why we have those core programs. So today, and on the final slide, we are now in 18 cities with these networks in various stages of development. And so it's how to take a local model and then replicate it and develop an infrastructure that's sustainable around replicating across their program. So while you may or may not be working with a model like this, the goal is to figure out replication. Now, that's the key as we move forward in this situation. And then finally, I'll just, nope, that's the wrong way. Okay, I don't know where we're at. We're fine. So I was going to show you a map of exactly where we are around the country, but that's not so important. I guess kind of the take-home message that I would have for all of you as you go on to this year is really tied to trying to really understand where we are in the trajectory of the epidemic and where the local communities that you're going to be working in, where they are in the trajectory of the epidemic, and how to tie in, kind of the vast amount of resources that you have and information that you have and insights that you have from their various experiences, but also figuring out ways how they tie back into the local communities that you're working in. My grandmother, always say that, in order that you cannot get where you're going if you don't know where you are. So the first step has to be knowing where you are. That's not just geographically speaking, that's not just linguistically speaking, that's not just culturally speaking. In all of the parameters, knowing where you are and figuring out how to maneuver through those processes. Many of you are going to be working in environments that are very different from the environments that you've been exposed to. Some of you are going to be in political climates that may not reflect your own values, And so how do you work in those climates? How do you meet people where they are and figure out how to get the best out of them where they are and living to fight another day to move them from where you need them to be? Now, I think one of the largest, most dramatic cases is what's happening in various parts of the world on LGBT issues. And that there are some countries where there's some awful things happening around human rights as it impacts LGBT issues. There are some places where there are horrible things happening with regards to women. And so how do you work in those environments and move the needle in those environments? And how do you meet people where they are and to get them engaged in what you're doing while at the same time trying to move them to a different place? Now, that's a serious challenge, and that is the key to where we need to be if we're actually going to move to an AIDS-free generation, and particularly if we're going to do it outside of developed countries. Now, we are not going to end the AIDS epidemic if we cannot end it in developing countries, full stop. The lessons that we learn here need to be able to be translated in other countries, and equally so, the lessons learned in developing countries can be very, very valuable to the work that we do in this country. So I will leave you with the following phrase, which I like to end all of my talks with, kind of a reminder that I remind myself of my personal journey and the journey to get us to where we are today. In 1996, I didn't know or think or believe, and didn't have any reason to believe that I would see the end of the AIDS epidemic, and now I'm committed to seeing the end of the AIDS epidemic. And because this epidemic will end, and when it does, it's important for them to know that we were not all monsters, that we were not all cowards, that some of us dared to care in the face of it, some of us dared to fight because of it, some of us dared to love in spite of it, because it is in the caring and the fighting and the loving that we live forever. Thank you.